Thank you, everybody, for being here this afternoon. And for those who I don't know, I'm Sandro Galea, and I have the privilege of serving as Dean of the School of Public Health. And this is one of our roughly monthly public health fora where we bring together real people who we admire, who we actually think are smart and thoughtful about issues that matter to the health of the public. So today we actually have an issue that's been very much in the public eye around the health of the public, which is universal coverage. As everybody knows, the country has probably been in the throes of discussing this notion of universal coverage, or some facsimile thereof, for at least the past decade, with first President Obama, and then, of course, President Trump trying to undo what President Obama does, and now we're in some sort of state that nobody understands, which is fine. So it feels to me like this is very much a topic for our time, has been a topic for our time for the past decade, and probably, frankly, will be a topic for our time for the next decade, or at least until we solve it as a country. We've seen plenty written about the fact that it is a bit of a scourge on the national conscience that we actually haven't solved it, and also other commentaries that's not something that actually matters and we shouldn't pay so much attention to it. So we invited today to speak somebody who I actually think will have a fairly interesting perspective on this. And let me introduce our speaker, Avik Roy. Avik is the president of the Foundation for Research on Equal Opportunity, which is a non-profit, non-partisan think tank that conducts research on expanding opportunity to those who have it least. If you look at Avik's bio, he actually has a very interesting bio because it features praise from him for him from the right and left of the political spectrum. National Review calls him one of the sharpest policy minds, while Paul Krugman, who is definitely not on the side of National Review, calls him a man of personal and moral courage. And you have things like the editor-in-chief of Vox, Ezra Klein, calling his blog one of the few blogs that I disagree with that I still check daily, which I feel like it's pretty high praise. Avik has also advised 3 presidential candidates, including who are Marco Rubio, Rick Perry, and Mitt Romney. I'll point out none of them won, so it's we need some work on that one. But as a senior advisor to Rick Perry's campaign, he was also the lead author of Governor Perry's major policy speeches. And I actually thought this was quite nice. The Wall Street Journal called Perry's address on intergenerational black poverty the speech of the campaign so far. Avik has written a book, How Medicaid Fails the Poor, published in 2013, as well as Transcending Obamacare, Patient-Centered Plan for Near Universal Coverage and Permanent Fiscal Solvency in 2016. I had the pleasure of meeting Avik a couple of years ago at a dinner, one of the dinners that we had hosted at the school as part of our 40th anniversary series of dinners. And we had a very lively dinner discussion about multiple topics around public health. And over the course of dinner, it became clear that Avik and I agreed on more or less nothing. And I think at some point I asked, how come you're at the dinner? And I think Avik said, it's because you invited me. And I actually thought that was really perfect. I think it's exactly why we actually have conversations. It's because we invite each other to learn from each other. So I'm now returning the favor and inviting Avik here to speak to us. Thank you for coming.
It's good to be with you. I spent a number of my formative years here in Boston. I went to college across the river, and my first job out of medical school was in a building directly behind us. And it was that work, accidentally, that led me here. I spent a bunch of years investing in healthcare companies, and particularly spending a lot of time analyzing the biostatistics of clinical trial data to figure out which breakthrough medicines were actually breakthroughs and which ones were false positives. And that led me somehow into a lot of research on healthcare policy, where I felt there wasn't a lot of good work being done digging into the statistics of health outcomes in our healthcare system and elsewhere. And here I am. The topic of today's talk, as you can see, is the conservative case for universal coverage. And why that topic? Or what am I trying to say? And part of what I'm trying to break through is there's been this dichotomy that we've had in the healthcare debate in America, right, where the cause of universal coverage has been traditionally, for the last 100 years, if not more, a cause of the left, one of the top priorities of the progressive movement in the United States. And on the right, the opposite's been true. The right has viewed with suspicion the ambition of people on the left to achieve universal coverage. And the first slide I'm going to have here, this is from a little kind of a YouTube or video-based TV show that the Hoover Institution at Stanford University does. You can see we're all kind of arguing over there. The guy just to my right in that photo is a guy with a beard, is a guy named John Podhoretz, who is the editor of Commentary magazine and one of the leading thinkers in the conservative movement. His father was one of the founders of the school of neoconservatism, which has different meanings today, but a guy who's very much been a part of the history of the conservative movement for the last 50 years. And he made this comment in our little argument there. He was complaining that this is a year ago today, so about, roughly a year ago today, in April of 2017, we're in the throes of this big debate as to what Republicans should do on repealing and replacing Obamacare. Many people in this room, many people on the liberal side would say, well, the biggest problem with the Republican plans to repeal and replace Obamacare is that fewer people would have health insurance as a result of the Republican plans. Well, that was not the critique of John Podhoretz. His critique was that it did too much to offer coverage to the uninsured, the Republican plan, that is. And in fact, this was a widely held view, if not an almost overwhelmingly held view on the right. That the flaw with the Republican plans, one of the reasons why the Republican plan polled so badly wasn't just because people on the left didn't like it. It was because people on the right thought it did too much to offer coverage to the uninsured. Because universal coverage has been so associated with the left, and the left's approach to universal coverage has involved an expansion of the role of government, the right's assumption has been, well, that's the only way to do it, right? The only way to achieve universal coverage is to expand the role of government. And so you read John Podhoretz here saying, well, the idea that there should be universal coverage for health care in the United States, that was never a conservative Republican goal. We have accepted an essential social democratic principle, and that's a huge concession. He saw this as the conservative movement has failed. The conservative movement is basically an empty shell because it's now accepting the principle of universal coverage. And I reacted vigorously to that because I find myself in a perhaps unusual place in this debate. That why is it that we equate a policy outcome, everybody having affordable health insurance in America, with a particular way of achieving it, doing so through, say, something like single payer? That's one way to achieve universal coverage, it's true. But that's actually a mistake sometimes we have in our own debate in America about health insurance. That we say, well, the only way to achieve universal coverage is through single payer. If you look at Europe, they're all single payer countries. Well, that's not true. In Europe, every country has a different healthcare system. It's a highly heterogeneous environment over there. Some of the countries are single payer-ish systems, and some of them are actually market-oriented systems, and that's something that's not widely appreciated. Here's an interesting table from the Heritage Foundation. The Heritage Foundation is a conservative think tank in Washington that many of you may know well. It was one of the prime drivers of Reagan's policy agenda in the 80s. They do this very interesting study at the beginning of every year called the Index of Economic Freedom, where they rate every country in the world on economic freedom. And you see here, this is the last year's chart. The United States is number 11 on economic freedom. And here are all the countries that rate above the United States: Hong Kong, Singapore, New Zealand, Switzerland, Australia, Canada, Chile, Ireland, Estonia, and the United Kingdom. Well, guess what? Every single one of those countries has universal coverage. Now, some of those countries have universal coverage that may not be more market-oriented than the United States, right? Like, so Canada has a single-payer system, as we know. The UK has almost a fully socialized system. So it's not that necessarily that the healthcare systems in those countries are more market-oriented than the United States, but some of them are. Singapore and Switzerland, I would contend, are significantly more market-oriented and more reliant on the consumer and on the private sector to deliver universal coverage than the US even is. But the most important part of this slide is the fact that there's been this mental block on the right. There's this assumption that, well, if we have universal coverage in America, that's a failure of economic freedom. Well, what this table is showing you is that actually that's not the case. That there are 11 countries, if not more, in the world that are more economically free than the United States that have also achieved universal coverage. Well, that may sound really confusing, and you may be really skeptical. What's he talking about? There must be some asterisk to this. This might be the most important slide I show you today. So you're all familiar with the blah, blah, blah slide, I call it. The slide that every health policy lecture begins with, in which somebody says the United States spends 18% of GDP on health care, And all the European countries spend 9 to 11% on healthcare, and our results are no better than theirs, right? This is like, almost like the prime directive of health policy lectures in the United States. Well, this chart is showing you something different, but arguably more remarkable. What this chart is showing you, and I know these numbers are hard to read up here, but this is showing you per capita public spending on healthcare, not total healthcare spending, just the government portion of spending on healthcare in the industrialized world. And here's something amazing. Government spending on healthcare per capita in the United States in 2012 was the third highest in the world. Right? So even though we had 50 million uninsured, we were spending more on healthcare than almost every other country. So if you look at, oops, excuse me, I advanced the slide too quickly. If you look at some of these other countries over here, let me see if I can go back. Here we go. If you look at the UK, right, the UK is right here. The UK spends something like $2,700 a year per person. We spend over $4,000 a person. Canada is, of course, cheaper. So, this is a point that you hear on the progressive side. Well, actually, if we had a single payer system, we'd spend less than we do now because we could have more aggressive control of access and price to actually keep spending down. And that's true. That's not the only way to do it, but that's one of the ways to do it. And this is the point I'm trying to say here to my conservative friends, is if you're concerned about how much we're spending on health care, and this is true for the progressive side too, it's not necessarily the case that spending more money is a solution. By the way, this is 2012 data. This is before the Affordable Care Act has gone into effect, right? So these numbers, if we looked at 2018 data, which we don't have yet, the government hasn't issued that data yet, this number is going to be higher, right? We might even be in second place or first place when you factor in the additional spending of the ACA. And that's what this next slide is showing you. So obviously conservatives get very agitated about the fact that the Affordable Care Act increases the amount of federal spending on health care to cover the uninsured. And when it's up and running fully, as it is almost today, the Congressional Budget Office expects that we'll be spending about $225 billion a year expanding coverage to the uninsured. And that's real money even in Washington. If you think about the federal defense budget, our entire federal defense budget is about $800 billion a year. So we're spending a quarter of the defense budget to expand coverage to the uninsured and the Affordable Care Act. It's a lot of money. But in fairness to the ACA, one thing we have to take into account is that the Affordable Care Act reduces spending on Medicare over a 10-year period by about $850 billion to partially offset that spending increase. So basically the ACA funds the increase in spending on the uninsured by reducing Medicare spending by $850 billion and raising taxes by $1.2 trillion over a 10-year period. And so if you actually net that out and say, okay, what's the net increase in spending under Obamacare? It's still real money, but it's less. It's about $75 billion a year. And hopefully will decline over time if those Medicare cuts have the effect that the designers of the law wanted to. But here's the real kicker. Okay, that's what Obamacare has done to change how much the federal government spends on health care. What were we already spending on health care pre-Affordable Care Act? And that's what these red bars will show you. So obviously we're already on the top floor of this building. I can't make this slide go down a few floors, so I'll compress it for you. The blue bars here, that's what Republicans for the last 10 years have been calling the government takeover of the healthcare system. And this is the rest of the federal spending on healthcare. It's primarily obviously Medicare and Medicaid, but also a few other programs. The point being that if you're a conservative who's concerned about Obamacare because you think it's the government takeover of the healthcare system because it's spending too much on healthcare, Obamacare is not the reason we're spending too much on healthcare. These legacy programs that came into place largely in 1965, the Great Society legislation that created Medicare and Medicaid, that's what's really driving federal spending on healthcare. We have a system-wide problem on healthcare spending that we don't solve, we're going to be in real trouble. Here's a way to really categorize how much trouble we're in. So the Congressional Budget every year, a budget office, which is the non-partisan fiscal scorekeeper in Washington, they put out this annual projection of 75 years of federal spending. Now you might say, how can you actually predict with any real accuracy what federal spending will be like 75 years from now? And the answer is you can't. But what the CBO tries to do is say, okay, if the laws that are on the books today stay the laws on the books for the next 75 years. So Congress doesn't actually change any of the laws. What are the obligations that the federal government has in the future? And what I've tried to do here is break it down into two categories: federal health care spending and everything else. So the everything else is the defense budget, it's Social Security, it's unemployment benefits, it's SNAP, it's food stamps, it's everything you think the government should or shouldn't be doing that it's spending money on other than health care. And so it's not even really an 80-20. As a share of economic output, it's more like 100% of the growth in federal spending overall is driven by health care spending. So if you're concerned about the fiscal challenges that America has in the future, which conservatives and Republicans at least claim to care about a lot, and one can debate whether certainly this Congress and this administration have lived up to that principle, but in general this is something that conservatives I think are genuinely concerned about. Healthcare is the biggest part of the problem. Well, there's one other category, actually I lied, there's one other category that's increasing federal spending, that's interest on the federal debt. So we're never going to really get to 2050 in this chart, because eventually the countries that finance our debt by buying treasury bonds will decide that we're never going to pay this off. Now you might say, well, why can't we just raise taxes to cover this? You can't raise taxes fast enough to cover the growth in interest on the federal debt and federal healthcare spending, because taxes would have to increase, revenues to the government have to increase by 6-7% a year. If our economy is only growing 3% a year, you just can't catch up. And what happens if we don't solve this problem? Who's going to suffer if we have to have draconian cuts to federal healthcare spending in the future, Greece style, in order to service the interest on the federal debt? It's not going to be most of the people in this room who will be able to afford private coverage even if the public system fails, right? It's going to be the most vulnerable people who depend on these programs who will suffer the most if these programs are cut in a drastic way as opposed to a gradual incremental reform that makes them more sustainable over time. So why is it that American healthcare is so expensive? And what are the drivers of it, right? You can see here that the two biggest components of federal spending, and as many of you know, are hospital care and professional services, of which the vast majority are physicians. And the third highest is drug spending, which is another $450 billion a year. And so, a lot of times when we talk about the high price of healthcare in America, there's this kind of funny, like musical chairs thing that goes on where the hospitals blame the insurance companies, the insurance companies blame the drug companies blame the doctors. Everyone is charging higher prices than they ought to. Actually, if anything, the insurance companies deserve less of the blame because they're just communicating those high prices that are charged to them in the form of premiums. Now, they could arguably do more to fight against that. But at the end of the day, it's the prices that hospitals and doctors and drug companies and medical device companies and lab companies are charging for their services that lead healthcare to be so expensive. And I'm going to illustrate that in the next couple of slides. So here's something you might not know. So you'll hear a lot of people in forums like this say, well, the way to solve the problem of the high cost of healthcare in America is we've got to reform the delivery system. We've got to move to value, and we've got to be more efficient at getting people out of the hospital, limit unnecessary care. Well, here's an interesting way to measure that. So average length of stay in a hospital is one kind of index, you could say, of the efficiency of your healthcare system. As we all know, hospital stays are very expensive. The longer you stay in a hospital, the more expensive your episode of care is. This is 2010 data, but this data really hasn't evolved over time in a meaningful way that's different. The United States actually, the average length of stay in a hospital in the United States is 3 days shorter than it is in the typical European country. So we're already much more efficient at getting people out of the hospital, in and out of the hospital, for a comparable episode of care. But what's the difference? Every day in the hospital costs 5 times as much in the United States. That's not because we're doing 5 times as much stuff to the patient. It's because we're charging 5 times as much for the MRI. We're charging 5 times as much for the respirator and the ventilator. This picture in the background, and it's hard to see in the light here, but that's Uwe Reinhardt, the eminent Princeton economist, who wrote a paper in Health Affairs about 10, 15 years ago called "It's the Price is Stupid," kind of trying to illustrate this point that utilization, volume, is not actually the problem in our healthcare system. It's the prices. And there's actually there was just a paper published in the Journal of the American Medical Association, I believe this current issue, maybe the last issue, but I think it's the current issue, by a couple of Boston academics that looked at this and found the same result. That if you actually compare the U.S. to other countries, in all the things about utilization that we think of as inefficient or unnecessary, we're actually either in the middle of the pack or ahead. It's the prices that are the problem. And it's not just hospital care, by the way. The price of a routine office visit in the United States is multiples higher than it is in other peer countries. And by the way, you all know about drugs, right? You all know that drug pricing in the United States is a problem, and that we spend way more on prescription drugs per capita than any other country in the world. But here's something you might not know, that the percentage of prescriptions in the United States that are for cheap, inexpensive, unbranded generic drugs is by far the highest in the world. So the typical European country, the percentage of prescriptions that are for unbranded generic drugs is about 21%. In the US, it's 82%, almost 4 times higher. And these are, again, the cheapest drugs that are basically less expensive to manufacture than a bottle of water. We're actually doing an incredible job with our system of, when a drug has gone off patent and a generic becomes available, shifting people to that generic drug. And if you're interested, we can go into all the technical reasons why that is. But we actually have the best system in the world for substituting generic drugs where appropriate for expensive branded drugs. The problem is the price of the branded drugs has exploded. We're actually spending, even though more and more prescriptions are for generic drugs, the amount we're spending on unbranded generic drugs, which are the white bars here, has actually declined in nominal terms, meaning that's not counting inflation. It's just on an absolute basis, we're spending less. But what we're spending on branded drugs has exploded by 50%, even though the vast majority of diseases can be treated with inexpensive, unbranded generics. So how do we actually get to this system? How do we arrive at this point where the prices of American healthcare services and products are so high? Some people, of course, argue that, well, it's because we don't have price controls. Well, it's true that we could have price controls, and that's one way to limit prices, but that's not the reason why prices are so high in America, right? Like, the price of a lot of other things we buy in the economy aren't high, right? Actually, American prices in terms of cost of living are lower than most European countries in almost every other sector of the economy. It's not because we have price controls in those other areas. It's because competition and innovation drive prices down. That's not happening in healthcare, where we've moved from that nice little old building at Mass General Hospital to this planet-eating system that's unaccountable to everyone. And how do we get from there to here? I'm going to argue that it's actually not that complicated. Our president believes that our healthcare system is really complicated. I'm going to argue that it can be explained in one chart. Here goes. You can tell me if I succeed. So in World War II in 1965, we said we're going to subsidize the cost of health insurance for people. But we did it in an unusual way. Those of you who studied this history, you know that in 1965 and in the decades prior, when Democrats were trying to install national government-run or government-subsidized health insurance plans in the U.S., there was a lot of opposition from the American Medical Association. The AMA was concerned that if the federal government was running and funding the healthcare system, that the federal government would be telling doctors what to do, and doctors don't like being told what to do, as most of you know. So they were adamant opponents to national health insurance. So LBJ was a very crafty guy, and he basically went to the AMA and he said, look, if you just shut up about my health care bill, I'll make you this promise. We won't put anything in there that tells you what to charge your patients. We'll allow you to charge, and the legal term is your usual, customary, and reasonable rates for your health care service. Hospitals too. So sure enough, the hospitals and the AMA said, okay, fine, we'll shut up about your Medicare bill, and it passed. Well, what did that mean? You have a system that subsidizes health insurance for tens of millions of Americans, but has no cost controls. So what happens? It's like me at an open bar, right? I mean, if I'm going to an open bar at an in-law's wedding especially, I'm not ordering the Bud Light, right? I'm getting the single malt scotch. And that's basically what consumers have done with healthcare in the last 50 or 70 years, is they go to the doctor, they expect it to be covered, whatever it is. They don't care. They become insensitive to healthcare costs because they're not directly paying for it. Well, what does that mean? Hospitals and doctors realized, and drug companies too, that they could charge higher prices and expand their offerings, knowing that nobody really cared that they were charging higher prices because the actual patient didn't see the bill, the real bill for the charges that were being issued in their name. That's, by the way, why a lot of hospitals are really ugly, as a lot of them were built in the 60s and 70s when American architecture was at its nadir. And, well, what happens then? The bean counters wake up and they say, gosh, we're spending more on healthcare than we thought. Here's an interesting piece of trivia. In 1965, when the Medicaid bill was going through Congress, the government, the predecessor to the CBO, you could say, estimated that in 1990, in inflation-adjusted dollars, we'd be spending $10 billion a year on Medicare. We were spending $110 billion a year on Medicare in 1990, and today we're heading towards $1 trillion. Why? Because of this open bar problem. If you create something that superficially seems free without any restrictions on cost or access, what's going to happen? People are going to consume a lot more of it, and people are going to become price insensitive. So what happens then? Of course, nobody wants to kick anyone off of Medicare because seniors vote, and no one wants to increase their premiums. So if you can't do that, what can you do? Well, you can hire managed care to be a bad cop to try to negotiate this problem away for you, and you can reduce what you're paying providers, hospitals and doctors, particularly hospitals, to try to manage this problem to a degree. Well, what happens then? The hospitals say, okay, we can't tell the government what to do, but we can tell private insurers what to do. So what we can do is merge so that we can create regional monopolies. In pharma, of course, if you have a new innovative drug, it's effectively a legal monopoly as a patent for 10 to 20 years. And then you can raise prices that way. That's basically what happened with the merger down the street between Mass General and Brigham and Women's. The governor of Massachusetts actually had to sign off on that deal. Charlie Baker, when he was the health secretary of Massachusetts, had to sign off on the deal. And he said since that he regrets it, that it was like throwing a grenade and it lands on the other side of the boat and it rolls back and explodes in your face. Because what happened was Mass General and Brigham and Women's merged. There was this big blue ribbon ceremony. Everyone's talking about how wonderful it was that these two jewels of the American healthcare system are going to merge and they're going to do so much for patients. Well, what did they do? They jacked up the price of everything they were doing by 10% every year for 5 years straight, right? That's what happened. And what do insurers do? Insurers are not in the habit of going bankrupt, so they charged higher premiums to make up for the fact that hospitals were charging higher rates for their services. And then we wake up one day and find out that tens of millions of Americans can't afford health insurance, and we decide to solve that problem by subsidizing health insurance for more people. Now, this is not to say that we shouldn't try to make sure that every American has health insurance. But it's that the particular and peculiar way we've done it in the United States has led to this incredibly difficult political problem, where it's easy to do this part politically, right? Subsidizing health insurance is relatively easy. Telling all these people that they should get less money is hard. And the way we built the system from 1945 and 1965 onward has made it very hard to attack the incentives that hospitals, doctors, drug companies, and all the rest have to charge high prices. So going back to this chart I showed you early on about the public spending on healthcare. And I mentioned that, of course, Canada and the UK, the countries we often look to because we can read their newspapers and say, hey, we should be like them. Yes, they would spend a lot. We would spend significantly less if we had the systems of the UK and Canada, which, by the way, pay hospitals and doctors a lot less than American hospitals and doctors get paid. But there are a couple of countries at the bottom of this list that are really intriguing, Switzerland and Singapore. As you may recall from one of my earlier charts, those are the two of the countries that ranked significantly higher than the US in economic freedom. And so when I make the argument to my conservative friends that, hey, universal coverage and more efficient government can go together, those are two of the countries that I like to point to. I'll try to explain what Switzerland and Singapore do that are interesting. So let's take Switzerland first. Switzerland basically has a system that's like the Affordable Care Act's exchanges, but for everybody. So as you know, the way the AC exchanges work is there's a regulated insurance market, and then there's subsidies to offset the cost of your premiums and your deductibles in some cases that gradually phases down as you go up the income scale. So if you're really poor, you get a full ride in terms of your tuition, your premiums. And then as you go up the income scale, you get a partial subsidy, and then it phases out entirely. But it's only for a limited income bracket, people who are making roughly between 1 and 4 times the federal poverty line. If you're above that, you have no subsidy, and if you're below that, you're on Medicaid. I'm oversimplifying, but that's basically how it works. In Switzerland, it's basically that system, but for everybody. So if your income is in the upper middle class or the really wealthy, you're getting no subsidy for your health insurance. Whereas in our system, through the employer tax code and through Medicare, we're actually heavily subsidizing health insurance for really wealthy people in our system. And because Switzerland doesn't subsidize upper income people, they subsidize basically the bottom third of the socioeconomic spectrum. They spend less than half of what we spend in terms of government spending on health care. They subsidize health care and health insurance for the people who really need the help, and basically not for anybody else. Singapore spends a fifth of what we spend in terms of public spending on health care. In terms of overall public spending, they're at 4% of GDP, so roughly a seventh of where we're at. So they have an incredibly outperforming system with in terms of the metrics you would look at for quality. Both of these countries are superior to the United States in terms of access to care, in terms of health outcomes, in terms of access to technology, in terms of choice of physician. So, you'll hear people say on the right, well, we don't want the systems of the UK and Canada because there's a lot of restriction of choice. You really can't go to the doctor you want, for example, and there's lots of long lines if you want to get your knee replaced. Switzerland and Singapore don't have these problems. Actually, they don't have the queuing problem. Access and waiting times are actually very, very short, but they also spend less than we do. So what is it that's in common in Switzerland and Singapore? In both cases, they subsidize health coverage for lower income people, but upper income people are unsubsidized, but they're private-oriented systems. So the thing about Switzerland is there's no public insurer. There's no public option. There's no Medicare or Medicaid like there is in the U.S. where, in the U.S., yes, private insurers can participate in those programs, but the base case is the government runs the system. There's no such thing in Switzerland. It's entirely private insurers. And it works pretty well, actually, because people in their cantons, which are the equivalent of our states, there's dozens of insurers who compete to provide those insurance products to individuals in that system. It's a lot like, again, not just the ACA exchanges, but similar to what Paul Ryan has advocated as a reform of Medicare. Singapore has a unique system that's very different from what we do. They basically have a single-payer system for catastrophic coverage. So if you get hit by a bus, you have cancer, you have a stroke, you're on a government-run, single-payer type system. But for everything else, what Singapore does is they take that portion of your payroll taxes, which goes to our equivalent of Social Security and Medicare, and a portion of that is rerouted into a health savings account that you control. And if you're lower income, if you have lower income in Singapore, that's topped off by the government. So you get a subsidy if you're in your health savings account if you're lower income. And you use that to shop for a lot of routine office visits, lab work, things like that. And that system also works pretty well in Singapore. The common element here is that how do these countries control costs? They control costs by putting consumers more in charge of the healthcare dollars that are being spent on their behalf. And the point I'm trying to make with that is there are basically two economically coherent ways to run a healthcare system. One is to do it the single-payer way, right, where the government's the insurer and the government regulates access to expensive services and regulates the price of services, right? You have cost controls and you have a subsidy for everybody. That's one way to do it. Or you can do it the Swiss or Singapore way where the consumer, the patient, is in control of those dollars, much like they are in the rest of the economy, and you have certain controls and safeguards to make sure that the system works for everybody and everybody can get access to health insurance. Either of those systems can work. What we do is combine the worst of both worlds. We subsidize health insurance for almost everybody, but we have no controls on price or access because we think that would be socialized medicine. And so we have this crony capitalistic system where the industry is in charge and patients are fleeced, particularly in terms of the taxpayer and what he's exposed to. So you might wonder, well, okay, that's all nice, Singapore, Switzerland, whatever. We've got a system here, and I'm happy with the reforms we've made. What's the argument for trying to reform the system in that direction, in a Swiss or Singaporean direction, let alone in a single-payer direction? So here I'm going to show you some slides of some things that are very worrying about our system in its current form. One of them is something we've alluded to earlier, which is hospital consolidation. We've seen the emergence over the last 10 to 20 years of regional hospital monopolies that take advantage of their monopoly power to charge higher prices for all sorts of services. This is a huge problem that almost nobody talks about. What you're seeing in this chart is the bars are the number of merger and acquisition transactions that have occurred in a given year. What happened is, you may remember that in the 90s there was this big wave of managed care. So it used to be basically insurance was this kind of sleepy thing where you'd have health insurance and the insurers would just pay the bills. Then people woke up and said, hey, that's not enough. We have to actually weed out waste, fraud, and abuse in the system, so we're going to work harder to kind of say no to things if hospitals do things that are wasteful. So what did hospitals do to respond to that? Emerge. So they would basically say, hey, we control all the hospitals in this metropolitan area, so you're going to have to do what we want. We're going to charge whatever we want. This green curve is showing you something called the Herfindahl-Hirschman Index, which is a measure that the Federal Trade Commission, the Department of Justice, and antitrust lawyers use to look at the market concentration of a particular sector of the economy. And the regulators say when the HHI gets over 2,500, it's the sum of the square of the market shares of a particular area, measured in the case of hospitals by discharges or admissions. Once it gets above 2,500, that's something where normally the federal government launches antitrust litigation. So when, for example, Time Warner and Comcast wanted to merge, and the FTC wanted to look at that, or when U.S. Airways and American wanted to merge, when those big national mergers happen, this is the metric they use to judge whether they should litigate or not. The median the median metropolitan area in America has a market concentration that in theory should invite federal regulation or federal litigation, but the federal government doesn't litigate it. So that's been a huge problem, is that we have this highly concentrated hospital market where, again, contrary to all the positive press releases about how this is going to integrate care and increase quality, the academic literature is that basically it has no effect. In some cases, quality and outcomes have gone down after mergers. There are actually diseconomies of scale when you create a more bureaucratic healthcare system. So while quality doesn't go up, we know prices go up. This is an elegant study that was done by a health economist at the University of California named Jamie Robinson. He looked at the average price of 6 common procedures: angioplasty, pacemaker insertion, knee replacement, hip replacement, lumbar fusion, cervical fusion, and said, okay, if you break all those metropolitan areas into 2 halves, the half that's more competitive and the half that's more consolidated, what are the prices? So the blue ones are the more competitive markets, and I'm going to show you the red ones, which are the consolidated markets. You can see that the prices, there's a clear correlation. If you're in an area where there's more consolidation, where there's one large hospital system or 2 that control the market, you have much higher prices, right? And this has been the business strategy of a lot of hospital systems around the country. I went to Yale Medical School. The Yale New Haven hospital system basically bought every hospital in Connecticut. Why do you think they did that? They didn't do that because they wanted the quality to be better. They did it because they could have pricing power of the insurers. If you're Aetna or United Healthcare or Blue Cross, you have no choice but to send your patients to a Yale New Haven hospital because Yale owns all the hospitals. So what does Yale do with that power? They raise prices. So that's hospitals. What about drugs? So here's a challenge that, again, we don't talk about a lot that I'm really worried about. And that is that so-called orphan drugs are already a quarter of all drug spending in the United States. And they're going to be a third within a couple of years. Orphan drugs, as you all know, are meant to be drugs for rare diseases, the rarest diseases in the world. The law defines them as diseases with under 200,000 prevalence in the United States, and Europe has a similar law. The idea was, in 1984, when this law was passed, well, we need to create a market for rare diseases because otherwise drug companies won't have an economic incentive to develop drugs for those diseases. And basically what this law has done is said, even if you don't have a patent, if you develop a drug for a rare disease, we'll basically give you an artificial patent for that drug for 7 years. And if you find another disease with the same drug, you can have another 7 years, another 7 years after that. And so drug companies have used this to create this massive new market where not only they have exclusivity, but they can also charge higher prices. Because who wants to be the insurance company that doesn't allow Genzyme to sell its drug to the kid with the genetic disorder, right? So what happens? Genzyme becomes a gigantic company, gets bought by Sanofi Aventis for tens of billions of dollars. because they're developing drugs for these ultra-rare diseases that affect 4,000 people in America and charge $300,000 per patient per year. And nobody complains, because who wants to complain about the innovative new treatment that cures a disease for kids with a rare genetic disorder, right? But this has become a public health problem because it's straining the ability of our system to finance pharmaceutical prescription drugs. So those are problems that kind of maybe incidental to or tangential to the way the Affordable Care Act actually works. I would say that hospital consolidation actually has accelerated under the ACA because of accountable care organizations and other incentives in the law. But here's another problem, which is the problem of how many people the ACA has actually expanded coverage to. It certainly has expanded coverage to many, but compared to what the expectation was of the law when it was designed and passed, it's underperformed. So this is looking at the exchanges. In 2010, the Congressional Budget Office projected that about 25 million people would be enrolled in the exchanges today. As we all know, those numbers those estimates have declined over time, and basically right now we're at 10 million people enrolled in the exchange. Well, why is that? It's basically because the premiums have been so high. As you all know, premiums in the ACA exchanges have basically doubled from the last pre-ACA year of the individual insurance market to what it is now. And why is that? And we'll get to that in a second. Actually, something else I should point out is I mentioned that there's a sliding scale of subsidies, right, where you get more of a subsidy if you're lower in the income scale, and you get less of a subsidy as you go up the income scale. So if you're close to 100% of the federal poverty level, almost everybody is signing up for the ACA, right? Because you're getting a full ride on your premium and your deductibles and things like that. But rapidly, almost a linear effect, as that subsidy phases out, fewer people are signing up. So for people who are near the poverty line, the ACA is actually working reasonably well because the premiums are paid for by the subsidies. But as you go up the income scale, that's when the ACA is really not succeeding. People who are, say, in the working poor or the lower middle class, they're the ones who are having the toughest time affording the ACA premiums if that's the market they need to go into. And why is that? The conventional wisdom, if you read the paper as well, the reason why ACA plans are so expensive is because they guarantee issuance of coverage to people with pre-existing conditions. What I'm here to tell you is that's not true at all. That's not true at all. If you think about it, it actually makes no difference whether you're required to issue insurance to someone who has a pre-existing condition. You could just charge them more money, right? The question is, what can you actually charge them for, and what can you not charge them for? And the biggest challenge with the ACA in terms of the premiums is something that's relatively obscure, and that is that the ACA requires insurers to charge the youngest people in its pool only 1/3 of what they charge their oldest people. So if you're 64, your premium can only be 3 times what it is for a 19-year-old. And why is that important? It's important because in our system, the average consumption in dollar terms of a 64-year-old in healthcare is 6 times what it is for a younger person. So you've compressed what naturally would be a 6-to-1 ratio to a 3-to-1 ratio. What's the effect of that? It's basically to double premiums for young people. And what do people do? What do young people do if you just double their premiums? A lot of them say, you know what? I don't care if there's an individual mandate. I'm not going to sign up for that, right? And that's been a huge problem. That's what has led a lot of people out of the market. And of course, if the young people drop out, what does that do? As you all know, it makes health insurance more expensive for the older people, and so some of them drop out too, right? And that's why the health insurance system that the ACA created has underperformed. And it's really driven by that age bands more than anything else, and then the dropout that results from that. There's been a degree to which the one-to-one gender rating has also played a role in the sense that a number of states, not Massachusetts, but a number of other states, had a system where you could charge men and women differently. This benefited, you could say, men who were younger, because if you were a woman of childbearing age, that can be a big expense. On the other hand, when you're older, it actually benefited women, because men tend to die of more heart attacks and strokes when they're 70s, and women live longer. So actually in that age band, if you get older, you start to see more effect, particularly in your 60s, of women actually having to pay more. But the end result is there are a lot of people, young men in particular, are the ones who are hardest hit by the way the ACA changed the market. And they're often the ones who are the most willing to go without health insurance anyway. So they've all dropped out. So that's the ACA exchange half of the market. As you all know, that was half of the way in which the ACA expanded coverage. It also expanded coverage through Medicaid. Now there, the enrollment piece has been, you could say, successful. The number of people who have enrolled in the Medicaid expansion has been equal to or greater than the original projections of the law. The problem with Medicaid is that a lot of people don't take Medicaid. So what this chart is showing you is the percentage of physicians who accept no new patient by insurance status, and this data is from 2008 because it's the last time this survey was done, and a low number is good. So if you have a low number, what it's saying is that you call up a physician who you don't have a prior relationship with, and you say, hey, will you take my insurance? And you say you have Blue Cross, you say you have Aetna. Only 5% of physicians will turn you down. Psychiatry is a spike because there are a lot of cash-paying practice in psychiatry, but in general, regardless of the specialty, you'll get access to a physician if you have private insurance. With Medicare, increasingly, and this disparity has widened over time, as Medicare rates continue to be compressed, a lot of physicians are saying, look, if you were a patient of mine and you graduated into Medicare, I'll keep you. But if your grandmother who moved from Buffalo to North Carolina to be with your grandkids and you need a new doctor, I might not take you because I don't have a relationship with you. And that's even worse for Medicaid. And again, this is 10-year-old data. These disparities have widened as the reimbursement rates between private insurance, Medicare, and Medicaid have widened as well. So this is the problem with Medicaid, and it's a problem that's getting worse because states are continuing to lower their reimbursement rates for Medicaid for budget reasons. So okay, that's what's wrong with the current system. What do the Democrats want to do? I've talked a lot about what I think Republicans should do, about what do Democrats want to do. As you all know, Bernie Sanders and friends think that, and maybe some of you in this room think, well, the way to do it is to do single payer in the US. And for better or for worse, single payer is not going to work in the US. It's not going to happen the way that we think of single payer. Because basically, the way the Bernie Sanders plan works is it would do nothing on the cost side. It would not pay doctors less. It would not pay hospitals less. It would not pay drug companies less. It would hope that the government leverage would allow that to happen in the future. But the plan would basically say, we're going to pay for everybody's health insurance, and that's it, full stop. Which, because you'd be taking federal responsibility for all the private spending we do in our system, and federal responsibility for all the state spending we do in our system, would increase the federal budget by 71%, not the healthcare budget. The entire federal budget. We increase federal spending total by 71% over the next 10 years. So that's not going to happen. Now you could say, well, if the Bernie plan paid doctors and hospitals half of what they pay now, which is probably what we should do, then that system could work. Yes. But guess who the second largest employer in every congressional district is? It's the hospital system. Right? Do you think they're going to be okay with Bernie Sanders telling them, no, we're going to pay you half of what we paid before? The hospitals will say, no, you can't do that. We'll close. And then your community will be out of hospital. And of course, no congressman wants that. So this system is not going to happen. That's not to say there couldn't be incremental reforms in a more left-wing or progressive direction. But this, which all you read in the paper about how Democrats are competing in terms of 2020 to come up with the most aggressive system on single payer, it's more rhetoric than reality, just like repeal was more rhetoric than reality. Okay, so I've complained a lot about everyone else. I'll spend my last few slides describing where I think we ought to go and where I hope we go. I think particularly as, now we've seen the Republicans run aground with repeal and replace. We will see, I think, Democrats run aground with expansive ambitions for single payer. What can we do? I think that there's a way, I would contend that there's a way to reform the ACA and the broader health reform system in a way that would make it more fiscally sustainable and cover more people with 4 basic elements. The first is to liberalize the ACA exchanges so you get the premiums down. As I've mentioned, you don't have to get rid of the things that everyone cares about, the pre-existing conditions protections, the gender rating protections. You don't have to get rid of those. You can preserve those, but reform some of the other regulations that have driven up the premiums unnecessarily. And you can also do things that are, depending on your terminology, either a high-risk pool or reinsurance, to make sure that we're doing more to direct subsidies to the sickest portion of the population that enrolls in these plans, which then lowers premiums for the healthier people who you want to be in the system. If you do that and you make that system work, where more people are enrolled and the system is stable and you don't have this adverse selection vicious cycle like we have right now, Then what can you do? You can actually gradually reform Medicare along the same lines. So why is it that we should all pay taxes in this room so Mitt Romney and Warren Buffett can be eligible for Medicare? We should be taking those tax dollars and spending them on the people who actually really need the help. Retirees who don't have a low net worth or a negative net worth and low income. And we can actually raise the eligibility age of Medicare gradually over time by several months a year once we've got the individual market worked out, because then, okay, if the exchanges are good enough for 64-year-olds, why shouldn't they also work for 65-year-olds and 66-year-olds? If you do that over the long term, over a 10, 20, 30-year period, the savings are incredible and make this system that right now has $47 trillion in unfunded liabilities permanently solvent. The next thing you can do is you can integrate Medicaid into those exchanges. So right now we've talked about this problem where Medicaid has poor access to providers. The exchanges have better access to providers. And so if you're a low-income, able-bodied individual who's basically on Medicaid because you're low-income and you want health insurance, meaning you're not disabled, you're not mentally disabled, you're not part of the disabled part of the Medicaid program, you're just somebody who needs health insurance, there's no real reason why those individuals shouldn't be in the exchanges. And that's really important for this reason. A lot of people whose incomes are near the poverty line, they go up and down month to month. So one month their income is at 110% of the poverty line. The next month they're at 80% of the poverty line. The next month they're at 0. The next month they have a job with employer-based insurance. And they're having to enroll in a different health insurance plan every month because of their eligibility for different government programs. And for people who are already struggling to keep their life together, why are we putting that burden on them? Why wouldn't we want them to be in an integrated system in which, yes, maybe the level of financial assistance they get goes up and down, but they're in the same insurance plan with the same primary care physician and the same provider network, so they don't have to have the discontinuity of care that they have under our current system. So we can dramatically make a difference on the quality of health care these individuals receive if we actually put them in an integrated system in which they have the same insurance plan through the year, regardless of their income status. And we can obviously do a lot of other things to tackle high drug prices, hospital consolidation. We can allow veterans to participate in the system, those who are unhappy with the quality of care they receive in the veteran system, and we can do something about medical malpractice too. When we did CBO-style modeling of this set of reform ideas, we found that you would reduce the deficit by $8 trillion over 3 decades. You'd make the Medicare trust fund permanently solvent because you'd be refocusing Medicare on, again, the people who really need the financial help. And by reforming Medicaid and basically taking over, making the federal government responsible for subsidizing insurance for the able-bodied, you'd massively improve state fiscal stability. So states would not have as much pressure in terms of how Medicaid is crowding out their budgets for education, policing, roads, and everything else. And you'd actually cover more people because you'd reduce premiums by so much that people who are uninsured today, who are not buying insurance because it's unaffordable, would have the opportunity to find affordable coverage in the exchanges. And that's really the thing about our healthcare system that's so remarkable, is that it's so messed up that both sides can win. We can actually cover more people and have a system that's less intrusive, less bureaucratic, and less efficient with taxpayer dollars, or so we would have more efficiency with taxpayer dollars. We can have less of a deficit, more of a sustainable system, the things that conservatives care about, while actually covering more people. And this has been the failure of imagination on the conservative side. The failure of imagination has been to say, hey, the only way to cover more people is by making the system more unsustainable. That's not true. If we actually learn from a lot of the European examples, we can make the system more sustainable while covering more people. And I think my one critique of the left would be I very much embrace and support and admire the left's advocacy of universal coverage, but I feel there's been a lot of complacency about how to actually learn from what countries are doing that might be more amenable to people on the center right, people who value that choice, who are concerned about the queues and the lack of choice in some of the single payer systems, say, hey, maybe there's a way to bring these two ideas together. And I will say, as many of you know about the history of this stuff, a lot of people on the Democratic side said, okay, the reason we're going to borrow from Massachusetts is because it was a Republican governor, it was the Heritage Foundation, this is the way we're going to have a compromise. And that's true to a degree. But there is a degree to which some base concerns of conservatives were not addressed in the ACA, particularly around the long-term fiscal sustainability of the healthcare system. And that's as much Republicans' fault as anyone else because they didn't engage as much as they could have. But the opportunity going forward is to do that. I think both sides have hopefully learned from both the political and the policy challenges that we've had over the last 10 years with our healthcare system. And my genuine hope is that by marrying these two goals, the great goal of the progressives to expand coverage to those who still don't have it, and the great goal of conservatives to make our system more fiscally sustainable, that if we put those two goals on the table and say those are going to be the two things that we care about, you can actually design legislation that achieves those two goals and actually solves a lot of the challenges that we have thought of as intractable and persistent in our healthcare system. So that was a lot of rambling. If you want to read more, if you really are a glutton for punishment, you can download the 102-page white paper at our website, freopp.org, and I hope I haven't eliminated any time for questions. So thank you very much, and I look forward to hearing what you have to say. My time remaining thing never went off, so I have no idea whether I went over my time or under my time or whatever, but 10 minutes. Okay, great. We have mics, so raise your hand and a mic will find you.
Thank you for these interesting proposals. At the beginning of your talk, you said it was price stupid. So how do your recommendations actually address price?
Yeah, great question. So I don't talk about it a lot in the slides, but in this 102-page white paper, we do address price considerably. There's a couple of things to say about price. One is you have to change the incentive structure of the system. When consumers are more in charge of the healthcare dollar and shop for their own insurance in particular, that creates a lot of positive incentives for price discovery and price efficiency. So in the exchanges, for example, one thing we've seen in the exchanges is narrow networks. Now, a lot of people complain about it and say, oh, narrow networks are really terrible. If you're a Republican, say, oh, this is really terrible, they're narrow networks, and even some people on the left complain about that. But actually, narrow networks are good because they hold hospitals accountable for non-cost-efficient care. And what the exchanges have shown is that if you give a patient or a consumer a choice between a plan with a lower premium in a narrow network and a higher premium in a broad network, they almost always prefer the lower premium and the narrow network, which has the secondary effect or second order effect of telling those expensive hospitals, hey, if you want to compete, if you want to get those customers, keep your prices down. So that's one important aspect of lowering price. Another is to tackle hospital consolidation. So there's a whole chapter in here on how to tackle hospital consolidation, both through more aggressive antitrust enforcement and also through a form of all-payer regulation where you say, if there's going to be a monopoly market in a particular region, we're going to treat them like a public utility. But if hospitals want to split up and break up and compete, that's fine. Then we won't be aggressive about price. But if you're going to be a monopoly, we are going to be aggressive about price. On drugs, actually, I have a separate paper called the Competition Prescription that talks about all the different ways that we can, while preserving innovation and the patents that go with innovation, make sure that we're not doing artificial things to create barriers to generic competition. Because generic competition is working, but it's only working or mainly working for so-called small molecules, pills, synthetic drugs that are basically very simple molecules. When you're looking at antibodies and other large protein-based therapeutics, that competition isn't working as well, and so we have to get the biotech side of the pharmaceutical industry to look more like the traditional pharmaceutical industry, where generics come in and really dramatically lower the price. So those are some of the examples, but I could go on. I could give a whole hour-long talk on that topic, so I hope that's at least a taste of it. Sure, go ahead. You got a mic coming.
Over the last few years, there's been big increases in the deductibles on health plans offered by employers. Has this had any effect on pricing or demand for services that employees attempt to obtain?
There is an energetic debate in the health economics community about whether we're seeing something like that. There has been, in certain areas of healthcare, a slowdown in spending. And there's been one in Medicare. There's been one to some degree, in certain parts of the private market as well. And in general, there's been a slowdown in per person in health spending because of some of these things that are attributed to some degree to high deductibles. but it's hard to disaggregate from some of the other effects we see. So for example, the fact that hospitals are consolidating and raising price, the fact that drug companies are increasing their prices by double digits per year, that's in a sense compensating for some of the effects. But there I think most people believe that there is some effect on prices and spending and consumption, certainly, that's coming from higher deductibles. And by the way, just to be clear, while higher deductibles may be part of the solution, they're not really the solution. Because what happens is, if you're a high utilizer, if you have a stroke or some other high cost condition, you blow through your deductible, and what happens after the deductible, the hospital's still not accountable for that price, So that's where shopping for the insurance plan really matters, and having that accountability for, hey, if you pick the second cheapest plan or the cheapest plan of the plans that are in your universe, you'll get an economic reward for that. Whereas if you want to pay for a really expensive plan that has all the bells and whistles, you might have to pay more for that, all else being equal. If you create that kind of a system, that's what the Swiss do, that really helps to create a competitive environment on those big ticket items. So deductibles alone, I think a lot of people say, oh, if you just have high deductibles, it's fine. That's not really true. For example, in the AC exchanges, the deductibles now are at $6,000. The Swiss system, it's considered a high deductible if it's $2,500. That's considered unacceptable in Switzerland, but some people choose those kinds. That's considered there's a statutory limit. You can't have a higher than $2,500 deductible right now in Switzerland. So they've managed to do it with lower deductibles than we have because their overall system costs and prices are so much lower. You in the back have been very patient by the cocktail table over there, and hopefully very warm because it looks like you're wearing a coat.
I am. It's very comfortable back here. That's why I got this table. I've been under the impression that administrative costs are different, and I don't think I heard you mention that. So the theory, right, is that if you have one system, right, a single payer, that the administrative costs would be very low. But if you have multiple insurers, the administrative costs are high because all of that has to be managed. Is there money to be saved in administrative costs, or is that a myth?
It's a myth, and I'll tell you why. So there's a couple elements of the administrative cost debate that I think are not widely understood. The first is what people often do is they compare Medicare's administrative costs to the administrative costs of other insurers. And the reason why that's an inaccurate comparison mathematically is that what are administrative costs? It's the amount you spend on overhead divided by the amount you're spending on healthcare claims. Well, if your only population is 65 and over, and you're comparing that to people who are younger, what are you going to do? You're going to have a lot more dollars spent with the 65 and older community versus the younger patients, right? So on a percentage basis, you're always going to have lower administrative costs for older people because the overhead's going to be less relative to the amount you're spending on healthcare. So if you actually measure dollar expenditure per enrollee in Medicare and take into account the fact that Medicare doesn't have to pay certain administrative costs because the IRS does all the tax collection, it's actually higher on a per enrollee basis than other health insurers. The other piece of it that's important to remember economically is think about a bank. Let's say you went into a bank and the bank had no security cameras and no security officers guarding their vaults, and their vaults were basically unsecure. They would be spending less on overhead, but that would also be a bank that have to spend a lot more money on insurance because they get robbed more often, right? And this is part of the thing. If you actually underinvest in administrative costs, you have a lot more waste, fraud, and abuse. And usually when we talk about administrative costs, we don't take that into account. Waste, fraud, and abuse becomes a bigger problem if you underinvest in the people who actually monitor claims for wasteful spending. So that's not to say we should be spending, crazy money, on like fancy hotels and seven-figure salaries, but should we be investing in the people who actually go through claims to make sure that people aren't wasting money and abusing the system? Of course we should. So I think the administration cost debate has been oversimplified by a significant margin. Yes.
One of the things which you've not talked about at all is the problem of information asymmetry, particularly in the pharmaceutical area. And it's across the board. The patient does not have any influence on actually what they're prescribed. And we have the example of pharmacies who have agreements with the pharmaceutical benefits managers where they have a gag rule, where they're not allowed under their contract to inform the patient that if they chose to buy the medicine for cash rather than with the insurance, the agreed insurance, they would save money. And that the true cost of these small molecule generics is often a 10th or 15th or a 20th of the cost that they're being charged. The same medicine that Walmart is selling at $4 a month will be sold for $20 or $30 in your pharmacy with insurance. And it seems to me that the need for information, transparency, and there has been an attempt for hospitals, for surgical outcomes and costs per outcome, but for the small molecule, the generics, which as you say is well over 80%, I think it's closer to 88% by volume, is what patients need to know about. Can you comment?
So there's two elements of your question. The first is the broader issue of economic question of information asymmetry, and the second is the specific examples of pharmaceuticals and pharmacies and pharmacy benefit managers. Let's take the first point first. So Ken Arrow, a famous economist at Stanford, first made this argument that, well, you can never really have a market-based healthcare system because there's information asymmetry. I vigorously contest that notion. There's information asymmetry in almost every area of economic activity. So the classic example is a house. The seller of a house knows more about whether that foundation is really good or whether it's rotting than the buyer of the house. And that's where the Latin phrase caveat emptor comes from, let the buyer beware. And there are certain, obviously, many regulations for fraud and misleading buyers in various segments of the economy. But the point is that there are lots of asymmetry is everywhere. When I go to the car shop and say, okay, there's something wrong with my car, I don't know what it is, can you figure it out? And you're trusting the mechanic to tell you that, okay, this is what's wrong with your car. He may be telling the truth or he may not be. Hopefully he's telling you the truth. And we could say that, well, healthcare is special because the consequences of deception are greater. But the reason I bring it up is that information asymmetry as an economic phenomenon is not unique to healthcare. It's everywhere. And technology is actually making information asymmetry much less of a problem, particularly as we think about the future of IT, right? Like today, we take it for granted that you have things like WebMD, where you can say, Google, I have this medical problem, what should I do? And you'll get some actually reasonable evidence-based information as to what people normally do in that situation. That's no substitute for going to a physician and getting a history and physical. But the point is, there are alternative sources of information today in ways that have never been true in history. And that's going to be even more true when artificial intelligence and machine learning allow you to enter your symptoms into a computer and review the latest evidence-based literature on exactly what your issues may be. That information is going to become widely accessible and probably more quickly than a lot of people anticipate. So all that to say that information asymmetry is not fundamental to healthcare. It's actually an engineering problem that can be solved over time by technology. And it's also not unique to healthcare, and so we can learn from the ways in which other sectors of the economy have addressed this problem to maybe find solutions. Then the specific point about the pharmacy and what you do there in terms of gag orders and things like that. Absolutely, we should do what we can to make sure that pharmacy benefit managers and pharmacies are not engaging in those contracts. The one thing that's true in some of these cases, it's actually federal policy that's created unintended consequences that create this problem of gag rules. So actually, you might even wonder why the pharmacy benefit manager industry exists. Why don't insurers directly negotiate with drug companies and pharmacies what the prices of drugs might be and how formulas may be structured? Well, it turns out there's a series of court cases that happened in the 90s that basically said that if pharmaceutical companies and insurers and pharmacies entered into those negotiations, they would be violating federal kickback laws. And the only way to avoid federal kickback laws was to create a new class of businesses that negotiated on your behalf so you were one step removed from what was going on. Right? So some of the things that go on in our system, they seem totally stupid, and maybe they are totally stupid, but they're actually the result of policy decisions that have had unintended consequences down the road. All right, well, I'm being given the hook, so I want to thank you all for listening to me and for all the great questions, and I look forward to talking more. Thank you.
Please join us.